So today we begin our series on injury. Normally there is one accident per minute in India, and every 4 minutes one person dies because of accident. Only 30% of accidents reach the hospital alive, and therefore the management of injury pre-hospital can save up to 70% of deaths. So today we will concentrate on head injury. 369 head injuries occur per 100,000 people per year. The disability adjusted life years lost because of injury. That means injury would produce disability as well as mortality. So, if a person is supposed to survive 70 years and he dies at 50 years, then 20 years are lost. And if you adjust it for disability, that is called as DALY, or disability adjusted life years lost per year. So this is a per year loss. So in the world, 4.7 DALYs are lost because of mild head injury, 5.4 because of moderate head injury, and 24.1 because of severe head injury. 60% of the injury patients that you see in the trauma center are head injury. The rest is chest injury, abdominal injury, pelvic injury, and limb injuries. So in this scenario, how to tackle health problems generated by head injury? So the first step of obviously the A is prevent them. Enforce use of helmets. This is the concept of backward seats that was given by Nitin Gadkari, because if this person collides, he will fall forward and hit against the obstruction. And if this person collides, the back seat would prevent most of the injuries. The third thing is use seat belts. And fourthly, United States was able to decrease injury-related deaths because of two-way highways. For example, if you are moving at 20 kilometers on this side and the other is moving 30 kilometers this side, the force of collision will add up as 50 kilometers. But if you are moving in the same direction on a two-way highway, then 30-kilometer vehicle starting 20-kilometer vehicle, there will be a difference of 10 kilometers. 10 kilometers will become the collision speed. So the two-way highways were able to decrease trauma-related mortality in United States of America. So the first thing is prevent injury. You will have to spend 400 rupees per disability adjusted life year saved in case of pre-hospital care. 14,000 rupees per DALY in case of hospital care, and 40,000 rupees non-recurring in primary prevention, for example, road design. So here you will have to spend 40,000 rupees per daily loss to prevent one daily loss. But this is non-recurring. All this cost 414,000 is a recurring cost. So you must concentrate on pre-hospital care. And in the pre-hospital care, you cannot have so many doctors and nurses. Therefore, you will have to train the first responder, the person on the spot. And the first instruction is save yourself first, move yourself and the victim to a safe place. Classify casualties into walking, talking, breathing, and bleeding, broken, dying. If the number is greater than 3, then it is termed as disaster. If the number of victims is greater than 3, and then you have to call for help. So you must know where to call and what to say. You must practice that. So call for help and classify casualties into walking, talking, breathing, and bleeding, broken, dying. You have to take help from the walking, talking, breathing and help the bleeding, broken, and dying. The bleeding is helped by hemostasis and early replacement of blood loss to prevent shock and to treat shock. Shock is not diagnosed by the cold, clammy skin and a gasping patient with dilated pupils, because if you diagnose shock by those physical signs, you have diagnosed shock for post-mortem purposes. Help the broken by splinting the upper limb and the lower limb, but also caring for the cervical spine by cervical collar and preventing lateral flexion of the cervical spine while you are trying to carry the patient in the decubitus position. Then the dying. What kills these patients? You have to take help from walking, talking, breathing and help the bleeding, broken, dying. And in the head injury, aspiration of the vomit or whatever is in the mouth will kill the patient, an unconscious patient. Others may die because of pneumothorax or cervical spine injury, which has not been properly cared for. Because if the cervical spine fractures, the phrenic nerve gets paralyzed, the intercostals get paralyzed, there's respiratory arrest, and the patients would die. So to prevent cervical spine injury, you must know how to take off the helmet without moving the cervical spine. And you must learn to apply a 4-post collar. And you must learn to prevent lateral flexion of the cervical spine in the lateral or coma position during transportation. In the unconscious, you have to clean the mouth and the throat to prevent aspiration. And you have to maintain what is called as the Bruchii space. The Bruchii space is between the tongue and the posterior pharyngeal wall, and through it, the air from the nose passes into the trachea. So in an unconscious patient, the jaw falls backwards. The genioglossus allows the tongue to go back and close this Bruchii space. Therefore, in an unconscious patient, you have to pull the jaw forward. You have to pull the jaw forward to maintain this Bruchii space, so that the air passage from the nose to the trachea is not obstructed. Then you have to transport in coma position, which is the lateral decubitus position, so that the vomit is not aspirated. So when you put the patient in the coma position, you have to prevent lateral flexion of the spine. And that you do by putting a pillow, the thickness of which is from the cheek to the bed, so that the neck stays straight. And there is no injury in a cervical spine fracture to the spinal cord. Then you have to transport the patient quickly, safely, and appropriately. Appropriately means that you have to transport to the place where all his problems can be managed and which is the nearest. And then the last is with full information. As you transport, the patient comes to the hospital and he encounters the first doctor. So anything that has been left above, you have to do that first. Then a head injury patient needs very good nursing care. So you have to have 3 nurses per 1 ICU or a HDU bed, and round the clock. You have to prevent bed sore by protecting the pressure points by a water mattress or an air mattress or a divided mattress, and by 3-hourly change of posture. You have to prevent aspiration, as I told you, by keeping the mouth and the throat empty and by maintaining the Brookie space in an unconscious patient. You have to prevent contracture by moving all joints that are not moving through their complete range every day. You have to maintain fluid and electrolyte balance. You have to maintain nutrition. And you have to prevent and treat lung infection by deep breathing exercises and by physiotherapy, and prevent hypostatic pneumonia by promoting drainage from the lung. In the COVID, you were told in the COVID pandemic that prone position helps better drainage of the lung. Then you have to detect paralytic ileus by abdominal distension, inability to pass stool, and treat it by nil orally, Rice tube suction, flatus tube, and IV alimentation. Then you have to manage a neurogenic bladder, initially by Foley's catheter, and then by intermittent catheterization, and then by evacuation by Creed's method if the post-void residual falls below 100 cc's. Then you have to understand that there is no sweating, therefore there is no thermoregulation. So you can manage pyrexia not by drugs that will promote sweating, but by cold sponging and keeping the patient in an air-conditioned atmosphere. So this is general about head injury. Then about the head injury itself, you have to watch for the signs of raised intracranial tension. Nausea, vomiting, headache, and slowing pulse and rising blood pressure. This indicates a raised intracranial tension, and you have to manage by hypertonic saline or mannitol. Steroids should not be given. Steroids are not indicated in this management of head injuries. But if they can be given if the blood pressure is falling. Then you have to look for pressure on the respiratory centers. Because if there is a supratentorial space occupying lesion, this lesion here, it presses on the tentorium cerebelli. This is the tentorium cerebelli. And as this tentorium cerebelli goes down, it presses on the cerebellum and the hindbrain, which start going down. So the first sign is that the sixth nerve, which is originating from the pontomedullary junction, emerging out, riding up the petrous temporal bone, then bending around its tip, which is called as the bend of wolf, going through the cavernous sinus lateral to the internal carotid artery, entering the superior orbital fissure and supplying the lateral rectus. So when this nerve is pulled here at this bend, it is the first to get paralyzed in supratentorial space occupying lesion. The lateral rectus gets paralyzed. The eye cannot move laterally. So when you move the head side to side in an unconscious patient, the eye that is trying to fix will not be able to move laterally. And this is called as the doll's eye movement, because in the doll you see that the eyes always try to fix in front. Subsequent to this, the respiratory center will get pressed as the medulla herniates through the foramen magnum. The breathing will become deep and fast, followed by slow and shallow. This is called as the chain stroke breathing. And then it becomes irregular, which is called as Bitort's breathing. And finally, there may be a respiratory arrest. So as soon as you get this paralysis of the lateral rectus, you should start arranging for the ventilator. And you should start planning decompressing the supratentorial space occupying lesion by creating a craniotomy in the supratentorial region. So the pressure will now not be going down, but will be dispersed after you have taken off a portion of the skull. So through that, the dura will bulge and the supratentorial space occupying lesion can be dealt with. So you've talked about irregular breathing, Bitort's respiration, chain stroke breathing, increased volume, increased rate, followed by decreased volume, decreased rate. Then respiratory arrest and how to manage it. The next thing is that there is a lesion which is displacing the brain laterally. So if this is the skull, this is the falx cerebri, then there is a lesion which can be extradural, subdural, subarachnoid, intracerebral, contacting with the ventricle or not contacting with the ventricle. And when this happens, the third nerve of the affected side is irritated and the pupil gets constricted on the affected side. Then as it gets paralyzed, the pupil starts dilating and finally remains dilated. Till then, the opposite side nerve gets constricted, so opposite pupil gets constricted and then it dilates. So unequal pupil is called as Hutchinson's pupil, and it indicates a lesion, intracranial space occupying lesion, which is displacing the brain laterally. So the brain can be displaced downwards or can be displaced laterally by a space occupying lesion, and this, wherever that space occupying lesion is identified by CT scan. You have to evacuate that lesion and you have to establish hemostasis. So the extradural lesion is because the middle meningeal artery, which enters through the foramen spinosum, it is reached by going through the pterion. You must remember the pterion. And by hemostasis is established by blocking the foramen spinosum. Subdural, subarachnoid or intracerebral lesions are approached by angioplasty. The hemorrhaging vessel is identified and obliterated by embolization. So after the life is saved and the damage is reduced, the residual disability has to be evaluated. In an unconscious patient, you have to continue with nursing care. In a bedridden but a conscious patient, you have to continue with nursing care and you have to provide him with occupation so that his mind is engaged and away from the thought of the disability. If that occupation leads to earning, that becomes vocational activity. Then you have to try to ensure that the patient is able to turn in bed, sit in bed, sit at the bed edge with legs hanging, then how to transfer from bed to chair. Then if the patient is able to walk on his two limbs, then you have to do gait training. Otherwise, you have to prepare him for wheelchair locomotion. After these basic things are taken care of, you have to take care of his activities, train him for activities of daily living, which means getting up in the morning, going to the bathroom, to the toilet, cleaning himself, shaving and brushing. Then you have to train him for social and recreational activities, for vocational activities where he can learn. And then you have to do a great deal to psychologically build him so that he comes in the stage of हार नहीं मानूंगा, रार नहीं ठानूंगा, काल के कपाल पर लिखता मिटाता हूँ. The famous poetry by Sri Atal Bihari Vajpayee. So the basic principle, friend, is minimize the disability and rehabilitate with the residual disability. The key word is persist without getting depressed. Thank you.